Hello, and thank you so much to the organizers for the opportunity to present at the first virtual GenTAC Aortic Summit. I'm really happy to speak here and happy to participate in the conference. My name is Shaine Morris, and I'm a pediatric cardiologist, and I specialize in imaging and epidemiology at Texas Children's Hospital in Houston. So I'm basically going to review briefly some common and novel imaging biomarkers and how they add to prognosis. And we're going to specifically talk how taking an image and looking at the image and deriving measurements or information from that image might be able to help providers predict risk of aortic dissection. So we're going to start a sort of a case of why this might be important. It's a case of an 18-year-old patient referred because of a pectus excavatum. And this is the echo you obtain. And you can see when you do the echo that there's moderate to severe aortic root dilation or aneurysm. And now we have to decide what the heck do we do with this patient. Now, the clinical questions that inform our decision-making are, what is this patient's risk of aortic dissection? That helps us to decide whether medical therapy is indicated, is surgery indicated yet? And we can get some information by doing genetic testing, but there's more to the story. We know that within families, people with the same gene have different risk of dissection, different likelihood of dissection, and is there information we can derive from the cardiovascular imaging to help us inform how to manage the patient? So is there additional information that can help with these decisions? So the challenge is that there's lots of phenotypic overlap. When you look at all these images, these are all aortic images from different patients in our clinical program. And they all have some degree of lengthening and dilation of their aortas. And how do we decide who is at risk of dissection? This first example is a woman with filament A deficiency. We know this is a smooth muscle disorder that can cause ascending aortic dilation and dissection. The second is a patient that has arterial tortuosity syndrome. This can cause significant arterial aneurysms as well as stenoses, but to date has not been reported with aortic dissection. ACTA2 mutations, like seen in the third person, can cause multisystem smooth muscle disorder syndrome, which is what this young woman has. And you can see she has pretty severe aortic root and ascending aortic dilation. And we know that there's a risk of aortic dissection in this population, but when do we have to worry? The last image is a patient with Loeys-Dietz type 4 who has a pathogenic TGF-beta2 mutation. And you can see from this image that the patient has already had a dissection in the arch and the risk was not recognized beforehand. And how do we recognize that a person is getting close to the time of dissection so that we can prevent it with surgery? So we're going to talk about different biomarkers. The first one some people wouldn't call a biomarker, but it is information derived from imaging. And we'll talk about aortic size. Now, of course, the most simple version of this is the maximum aortic dimension. It's what's most used commonly to decide about aortic surgery. Now, the problem with this is, are you getting this image from an echo or MRI or CT? And how are we measuring it? Are we measuring it in systole, in diastole? Are we measuring it leading edge to leading edge, inner edge to inner edge? Which one do we do? And if we get it from CT or MRI, where do we measure it? Do we measure it in the long axis, mimicking what we see on echocardiography? Do we measure it on an MRA, but which might have blurry edges if it's not gated? If we do measure it from cineographic imaging, which gives the clearest image, and we do it on FOSS, do we measure it from cusp to commissure? Do we measure it maximum cusp to cusp, or do we measure it mid cusp to cusp? All of these methods are published in the literature, and we don't really have great predictions for dissection. The best papers predicting dissection are from old echocardiographic data. So really, this is a suboptimal tool. Now, unfortunately, our best prediction algorithms for dissection still are based on aortic diameter. This first figure is from the French group that says, as your aorta gets bigger, the likelihood in Marfan syndrome, this is specific to Marfan syndrome, is dying the bigger your aorta is. So once your aorta is 55 to 59 millimeters, your likelihood is up to 25% risk. However, when we look at those cutoffs, if we make a cutoff and we say, okay, well, we're going to cut off at 50 to 55, we really do miss a lot of aortic dissections. It's a histogram of aortic dissections by aortic dimension in Marfan and non-Marfan syndrome. So we know that while this cutoff is nice, we still miss a fair number of patients. So really not a suboptimal, or really not an optimal biomarker. We would hope that there's something else we can use to make these predictions more sensitive and more specific. This is now again looking at Loeys-Dietz syndrome and looking at aortic dimension. This is one of the largest studies done by the MAC consortium. If you look here, this is age, but this is millimeters at first aortic event. And you can see that they're all over the place. So if we operated on everyone at 4, while yes, we might prevent a large number of dissections, a lot of people are having interventions far earlier, maybe 10, 20, 30 years before they would have had an event. And is that really the best strategy either? We really obviously need something besides aortic size. So now what about permutations of aortic size? What about aortic Z-score? We use aortic Z-scores a lot in pediatrics to sort of normalize for age, for height, for weight, for body surface area, possibly race, ethnicity. The challenge is aortic Z-score does not really change over time. So it's not a great biomarker because it minimally changes. I can tell you as a pediatric cardiologist that someone with Marfan syndrome who comes in with a Z-score of 4 when they're 2 years old is probably going to have a Z-score around 4, maybe lower when they come at 15. It's just that they get to a risky size earlier, but you can't really follow and say, well, okay, when the aortic Z-score is 5, I'm going to operate, because a person's personal Z-score does not change that much over the course of life. This is like a static Z-score. For sure, people that have higher Z-scores are more likely to dissect, but that's at some point in their life. It doesn't tell you, well, they have a higher dissection risk in 2 years than the other person. Now, what about aortic area index for body surface area? There has been some work using this as a different kind of indexing tool, and most commonly this paper by Dr. Davies and his group at Yale. However, there hasn't really been great additional data to say that this outperforms aortic dimension or Z-score when we're trying to predict aortic dissections. Now, what about biomarker number 2? Now, this is the biomarker of adding a bicuspid valve in connective tissue disorders. First, we're going to talk about in Marfan syndrome. So there have been a few papers, this is an example of one of them, looking at the significance of having a bicuspid aortic valve on top of Marfan syndrome. Does this help you predict risk? Now, certainly they showed, and others have shown, that if you have bicuspid valve on top of Marfan syndrome, you're more likely to have a more dilated sinus of Valsalva, whether you measure it in millimeters or Z-score. And this has also been shown for the ascending aorta. However, in this study and other studies, it does not really seem to be associated with risk of dissection. So you have a biomarker that says, okay, the aorta is going to be bigger, but does it really predict dissection? That is unclear so far. This is similar data from our cohort in Loeys-Dietz syndrome. So just to orient you to these two graphs, this first graph is aortic root diameter. These are the mean growth rates. This is aortic root Z-score. And each line is an individual patient. The red lines are patients with TGF-beta2 variants. The blue lines are TGF-beta1 variants, and the green lines are TGF-beta2 variants. The dots are patients who required an intervention, and the stars are patients who have bicuspid valve. So you can see in this cohort that bicuspid valve was only seen in our patients with TGF-beta2 variants. And in this cohort, certainly the presence of BAV on top of a TGF-beta2 variant was associated with much more rapid dilation. And one of these patients had a dissection. But again, that's not enough data to say that a BAV is a biomarker of dissection, because it's something present from birth. So it does say your overall lifetime risk is higher, but it's not something you follow and say, okay, I think you're more likely to have a dissection. Now, what about arterial tortuosity? This is a biomarker near and dear to my heart, and I like to look at this and I like to study it. We know that patients with both Loeys-Dietz and Marfan syndrome, so who have increased arterial tortuosity, most often measured in the vertebral arteries, but can be measured elsewhere, have a higher risk of aortic dissection. This was shown in a more recent cohort of ours looking at just type A dissections, and people with a higher height-adjusted vertebral artery tortuosity index were more likely to have type A dissection. However, one of the limitations of tortuosity is it does not change much with age. In fact, it decreases a bit during adolescence. So it's more of a stable biomarker like genotype, like bicuspid aortic valve, like Z-score, where if you see someone with arterial tortuosity as a young person, you can say your lifetime risk of dissection is higher, but that needs to go with a dynamic risk predictor with perhaps aortic dimension to say, is your risk increased at a smaller diameter compared to someone else? We really need to work for additional dynamic biomarkers. Now, of note, arterial tortuosity is a risk factor for aortic dissection. It's been validated in multiple studies now. One of note is the Dutch randomized controlled trial of medical therapy in Marfan syndrome showed that increased aortic tortuosity was associated with increased risk of aortic dissection. Now, what about biomarker number 4, aortic stiffness? So multiple papers have shown, both in connective tissue disorders and without connective tissue disorders, that patients with a more stiff aorta are more likely to dilate faster. So this is, I'm using as an example, this paper from Circulation in 2015, looking at a young cohort. We're looking at root strain. And the higher your strain, the less stiff you are, and the lower your strain, the more stiff. So they show that patients with lower root strain were more likely to have aortic surgery. We looked here, and this is showing that root strain correlates with aortic dimension. And they were looking at circumferential aortic root strain and saying that increased risk of dilation. However, they did not show a significant association with dissection. They did look at multiple measures of aortic stiffness, strain, distensibility, beta stiffness index, and pulse wave velocity, but only showed that circumferential aortic strain was associated with dissection. Now, the Spanish group published this paper recently also evaluating aortic strain, but they actually showed that circumferential aortic strain was not associated with outcomes once they controlled for aortic root Z-score. So they said sort of those are really collinear aortic root strain and Z-score, and once you account for Z-score, which is more readily available, that the strain was not that contributory. However, they had a different kind of strain, longitudinal aortic strain, which is how much the aorta root or valve moves during the cardiac cycle, and the stiffer or less strain the patient had, the more likely they were to have an aortic dissection. And interestingly, work similar to this have been published back in 2004 in Circulation, looking at the movement of the aortic valve. And the more stiff or the less movement, the higher likelihood of dissection there was. Now, what about 4D flow as another biomarker? Well, 4D flow is super fun. We are doing it. I love to look at it. I love to see the streamlines. I love to look at the wall stress. But still to date, we don't have great measures and enough pre-dissection imaging to say this is what 4D flow looks like before a dissection. We can certainly say different genotypes have different characteristics. We can certainly say how 4D flow might look differently with an aortic aneurysm, but we don't really have great data yet to say if you see this pattern, there is an impending dissection, but hopefully we can work more with 4D flow to get there. And lastly, back in the mid-2000s, there were 2010, 2014, there has been some work on elastin-specific MRI, mostly in animal models, and saying, okay, if we can do an MRI to show areas of elastin deficiency, which certainly we see in connective tissue disorder, and if this is happening over time, maybe we can predict areas that are susceptible to aortic dissection. It's very exciting work. However, this really hasn't panned out or been further investigated in the connective tissue community. There have been a few papers looking at abdominal aortic aneurysm, which is an inflammatory process, and that this kind of MRI, specifically tropoelastin, sort of a different kind of MRI, might be helpful. And so maybe this is a further area of investigation, but my understanding to date is it hasn't really been as strong as we were hoping as a biomarker of aortic dissection. So basically, in conclusion, imaging biomarkers have significant potential, but there's no dynamic, meaning constantly moving biomarkers that have excellent discrimination when we are trying to predict aortic dissection. Now, the biomarkers that have been associated with aortic dissection are aortic dimensions, arterial tortuosity, and aortic longitudinal strain. However, how these move over time in predict dissection is still really unclear and not that wonderful to date. And basically, as we know and as we keep hearing, management decisions regarding these patients are complex and only getting more complex. And probably modeling is not going to be looking at one image and deciding if they're going to dissect. It's probably incorporating both static and dynamic risk factors. It's taking things that are constantly moving like aortic dimension, taking static factors like bicuspid valve, sex, genotype, tortuosity to try to predict who is going to have a dissection to optimize care. Thank you so much for listening to the presentation, and I look forward to any questions in the future if necessary. Thank you.